Gout, historically termed the king of diseases and the disease of kings, remains a quintessential example of how lifestyle factors intersect with metabolic pathology. While the imagery of gout often evokes scenes of Regency-era nobility, indulging in lavish feasts and excessive alcohol, modern medicine defines it as a crystal-induced arthropathy driven by hyperuricemia. This condition results from an imbalance where the serum concentration of uric acid exceeds its solubility limit, typically 6.8 milligrams per deciliter, leading to the deposition of monosodium urate, MSU crystals within synovial fluid and soft tissues. The pathophysiology is based on purine metabolism. Uric acid is the final breakdown product of purine nucleotides, a process mediated by the enzyme xanthine oxidase. It is vital to distinguish between underexcretion and overproduction. Approximately 90% of patients are underexcretors, often due to idiopathic renal mechanisms or the use of thiazide diuretics, which compete with uric acid for secretion in the proximal tubule. Conversely, overproducers may suffer from high cell turnover, such as in myeloproliferative disorders or tumor lysis syndrome, where the massive release of nucleic acids overwhelms the body's clearance capacity. Genetic deficiencies, specifically Lesch Nyhan syndrome, a deficiency in HGPRT, also lead to profound overproduction and neurologic symptoms. Clinically, an acute gouty attack typically presents as podagra, exquisite pain, warmth and erythema at the first metatarsophalangeal joint. This inflammatory cascade is triggered when monosodium urate crystals are phagocytosed by neutrophils, activating the NALP3 inflammasome and releasing interleukin-1 beta. Under polarized light microscopy, these crystals are pathognomonic. They appear as needle-shaped and exhibit strong negative birefringence, meaning they turn yellow when aligned parallel to the slow-wave compensator. Chronic management focuses on lowering urate levels to prevent tophi, chalky, subcutaneous deposits, and urate nephrolithiasis. While NSAIDs, colchicine, and steroids manage acute flares, xanthine oxidase inhibitors like allopurinol are the mainstay for prophylaxis. However, clinicians must screen for the HLA B *5801 allele in high-risk populations to avoid Stevens-Johnson syndrome. Despite the persistent stigma of overindulgence, gout is a complex metabolic bridge between genetics and diet, requiring a nuanced understanding of biochemical pathways and renal handling to treat effectively. The historical lineage of gout provides a fascinating backdrop to its modern clinical presentation. When Hippocrates described the unwalkable disease, he was noting the debilitating nature of acute inflammatory arthritis. It is crucial to recognize that this inflammation is not merely drops of humors, but an immune response. While the Greeks focused on the big toe, or podagra, the boards often test the systemic implications. The unwalkable nature of the flare is due to the rapid recruitment of neutrophils. Colchicine, a classic treatment derived from the autumn crocus, works by binding tubulin to inhibit microtubule polymerization, thereby preventing the very chemotaxis and degranulation that Galen might have attributed to, quote, debauchery. The transition from ancient impurities to modern biochemistry reveals the role of alcohol, particularly beer, which is rich in guanosine purines. Ethanol also increases the production of lactic acid, which competes with uric acid for excretion in the renal tubules, providing a metabolic explanation for the drunkenness association. This competition often leads to an acute spike in serum urate levels, precipitating a flare. Furthermore, the arthritis of the rich often involved high intake of fructose and red meats, both of which accelerate purine turnover. In the chronic phase, the drops become tophi, visible, firm, non-tender nodules that can mimic rheumatoid nodules or even infection. Histologically, these represent a granulomatous response to the monosodium urate crystals. One must differentiate gouty tophi from the Bouchard or Heberden nodes seen in osteoarthritis, which are bony overgrowths rather than crystal deposits. The ancient observation of podagra remains the most common initial presentation, but the involvement of the olecranon bursa, or the Achilles tendon, is a high-yield clinical pearl for identifying more advanced cases. The historical stigma often overlooks the role of lead poisoning, the Saturnine gout of the Roman era, where lead-lined wine vessels caused chronic tubulointerstitial nephritis, impairing urate clearance. This serves as a reminder that renal health is the primary determinant of urate homeostasis. Whether triggered by the thiazide diuretics used for hypertension or the aspirin that inhibits urate secretion at low doses, the king of diseases remains a masterclass in the intersection of history, biochemistry, and renal physiology. Understanding that gout is actually a crystal-induced cytokine storm allows for a sophisticated approach to both diagnosis and long-term management. The historical portrait of gout as a moral failing reached its zenith during the Enlightenment, where the physical manifestation of a swollen limb became a visual shorthand for a life lived without restraint. While royalty like Henry VIII and Louis XIV provided the blueprint for the gouty despot, the 18th century caricature transformed the condition into a political and social weapon. The bandaged leg of George IV was not merely a medical reality, but a symbol of the bloated state of the monarchy, expensive, immobile, and over-leveraged. In these satires, the gutta, or drop of poison, was seen as the inevitable byproduct of a body politic that had consumed more than it could ever hope to digest. Beyond the palace walls, this era of history coincides with the rise of the port wine gout phenomenon. The Methuen Treaty of 1703 facilitated the mass importation of fortified Portuguese wines into Britain, which were often stabilized with lead-based additives. This historical nuance reveals that the gluttony of the era had a hidden chemical catalyst: lead-induced nephropathy. Chronic lead exposure damaged the proximal tubules of the kidney, the very site responsible for the active secretion of metabolic waste. Thus, the nobility were not just suffering from sumptuous banquets, but from a secondary form of the disease where the kidneys lost the ability to clear organic acids, leading to the painful crystallization that haunted the likes of George IV. The societal perception of the gouty gentleman created a unique medical paradox. Because it was an affliction of the elite, it was occasionally viewed with a perverted sense of pride, a nobleman's distemper, that distinguished the wealthy from the laboring classes who supposedly lived on simpler, more virtuous fare. However, the agony of the condition usually stripped away any such prestige. The transition from a mark of status to a signifier of moral corruption occurred as the middle class expanded and the virtues of temperance began to take root. The swollen joint became a site of judgment, where the internal metabolic failure was projected as an external lack of character. This era of medical history serves as a reminder that the understanding of disease is rarely confined to the laboratory or the clinic. It is shaped by the cultural anxieties of the time. The transition from seeing gout as a divine punishment for royal excess to recognizing it as a systemic metabolic disorder required a shift away from the satirical lens of the 18th century toward a more rigorous analysis of renal function and chemical precipitates. Even as we move toward a molecular understanding of the disease, the echoes of these ancient and royal stigmas continued to color the public's perception of the condition long after the banquets had ended. The cultural elevation of gout, from a simple physical ailment to a mark of high breeding, represents a fascinating chapter in the evolution of social status. In the 17th century, the belief that certain diseases were reserved for those of refined stock allowed the sufferer to frame their intense physical agony as a badge of socioeconomic achievement. The fable of the spider and the gout perfectly encapsulates this sentiment, suggesting that the disease itself possesses a discerning palate and a preference for the comforts of the aristocracy. In this narrative framework, the spider finds peace in the dusty corners of poverty, while the gout finds its sanctuary in the velvet-draped chambers of the wealthy. This personification of the illness transformed the inflammatory process into a guest of honor, one that only visited homes where the floors were polished and the pillows were made of the finest down. This social distinction was reinforced by the emerging understanding of lineage and the hereditary nature of the condition. Because the disease frequently appeared in successive generations of royal houses, a sudden swelling of the joint could be interpreted as a biological confirmation of noble blood. It suggested that the individual possessed the same physiological vulnerabilities as kings and queens, thereby distancing them from the laboring classes whose bodies were supposedly hardened against such refined afflictions. During this period, the presence of the disease could even be used to justify political or social standing, as it implied a life of leisure and the financial capacity to afford the very foods that triggered the metabolic crisis. The physical manifestations of the disease, such as the formation of firm nodules known as tophi, were viewed not just as clinical complications, but as permanent markers of a luxurious history. These deposits, often appearing on the ears or the small joints of the hands, served as visible proof of one's participation in the upper echelons of society. Unlike the infectious diseases that ravaged the crowded urban centers of the poor, this was an internal collapse of the body caused by the finest things in life. It was a condition that demanded a sedentary lifestyle during its acute stages, further aligning the patient with the idle rich who did not need to perform manual labor. By the time the 18th century arrived, the concept of the noble sufferer was deeply ingrained in the public consciousness, creating a unique medical identity where pain was inextricably linked to power, prestige, and the perceived virtues of an ancient family line. The notion that gout served as a protective shield against more lethal maladies represents one of the most intriguing chapters in the history of pre-modern medicine. Within the framework of the medical understanding of the time, the human body was viewed as a vessel of competing forces, where one ailment could potentially crowd out another. This led to the curious belief that a robust case of gout was a sign of a strong constitution, acting as a metabolic lightning rod that drew dangerous imbalances away from the vital organs like the heart and the brain. Patients often welcomed the throbbing pain in their extremities if it meant they might avoid the sudden stroke or the lingering consumption that claimed so many others. This conceptualization of the disease as a talisman transformed the sufferer from a victim of a painful condition into a fortunate survivor who had successfully bargained with death by sacrificing the comfort of their feet for the safety of their soul. This perceived benefit created a culture where the traditional remedies of the physician were often treated with a playful skepticism. In the vibrant social circles of the 18th century, the image of a patient tossing their medicinal tinctures and powders into the fireplace while raising a glass of fine champagne was more than just a joke. It was a statement of defiance against the somber and often ineffective medical practices of the day. The sparkling wine was not merely a luxury, but was seen by some as a superior tonic that maintained the elevated spirits necessary to keep more depressing illnesses at bay. If the champagne fueled the gout, then the gout in turn guarded the gates of the body against the entrance of deadlier fevers and plagues. This circular logic allowed the wealthy to persist in their habits with a sense of medical justification, viewing their swollen joints as the price of a life lived in high spirits and relative safety from the common infections of the masses. As the understanding of human physiology began to shift toward a more systematic observation of symptoms and outcomes, this idea of the protective disease started to fade. However, the legacy of the gouty lifestyle remained a powerful cultural archetype. The celebration of the champagne lifestyle over the bitter draughts of the apothecary reflected a broader desire to control one's own health through indulgence, rather than through the deprivation and purging that dominated standard medical care. This historical perspective reminds us that for centuries, the experience of illness was not just a biological reality, but a deeply social and even psychological defense mechanism. The gout sufferer was a figure of complex contradictions, navigating a world where the most intense physical agony could be interpreted as a life-saving blessing, and where a bottle of wine was considered a more reliable ally than the leading doctors of the era. This unique intersection of medicine and social status ensured that the disease remained a central pillar of the cultural imagination for generations. The clinical reality of this metabolic disturbance stands in stark contrast to its comedic portrayals in historical art. When Thomas Sydenham described the nocturnal onset of symptoms, he was documenting a hallmark of the condition that modern science attributes to the lower body temperature and relative dehydration that occurs during sleep. These physiological changes decrease the solubility of monosodium urate, leading to the rapid precipitation of crystals within the joint space. The description of a pain so exquisite that even the weight of a bedsheet is unbearable highlights the profound inflammatory response triggered by the innate immune system. This process begins when the sharp, needle-like crystals are recognized by resident macrophages, which then activate the intracellular protein complex known as the inflammasome. This activation results in the massive production of pro-inflammatory cytokines, specifically interleukin-1 beta, which recruits a torrent of neutrophils to the site of the perceived injury. The intensity of this response explains why the affected area becomes erythematous, warm, and severely swollen, often mimicking the appearance of a soft tissue infection or cellulitis. While the first metatarsophalangeal joint is the classic site of involvement, the inflammation frequently extends to the midfoot, the ankle, and the prepatellar bursa of the knee. If left unmanaged, the recurrent cycles of inflammation led to the formation of tophi and permanent joint destruction, a process characterized by well-defined, punched-out erosions with overhanging edges of bone that are visible on radiographic imaging. These structural changes represent the transition from episodic flares to a chronic, polyarticular state that can severely limit mobility and quality of life. The systemic nature of the disease also has significant implications for renal health. The same crystals that deposit in the joints can also form stones within the collecting system of the kidneys, particularly in an acidic urinary environment, which further reduces the solubility of uric acid. This can lead to obstructive uropathy or chronic urate nephropathy, where the deposition occurs within the renal interstitium itself, sparking a chronic inflammatory reaction that impairs kidney function over time. Therefore, the management of the condition extends far beyond simple pain relief. It requires a comprehensive approach to lowering the total body burden of urate, often through the long-term inhibition of the enzyme xanthine oxidase. By blocking this pathway, the production of the offending substance is curtailed, allowing the body to slowly reabsorb existing deposits and preventing the catastrophic inflammatory cascades described so vividly by Sydenham centuries ago. Understanding these underlying mechanisms reveals that the ancient unwalkable disease is a complex systemic disorder requiring precise pharmacological intervention to protect both the skeletal and renal systems from irreversible damage. The history of gout therapeutics represents an evolution from the speculative rituals of bloodletting and topical chemical dressings to a precise understanding of cellular mechanics. Among the myriad folk remedies, the autumn crocus, also known as Colchicum autumnale, stands as a singular bridge between the medieval apothecary and the modern clinical pharmacy. Long before French chemists isolated the active alkaloid in the early 19th century, the plant was recognized for its potent ability to halt the explosive pain of an acute flare. In the modern medical landscape, this traditional extract functions through a highly specific mechanism of action that targets the very heart of the inflammatory response. By binding to the intracellular protein tubulin, the drug prevents its polymerization into microtubules, which are essential for the structural integrity and motility of cells. This disruption effectively paralyzes the white blood cells, particularly the neutrophils, preventing them from migrating to the joint space and releasing the destructive enzymes and cytokines that characterize the disease. The use of this ancient alkaloid requires careful consideration of its narrow therapeutic window and its systemic effects on rapidly dividing cells. Because the drug inhibits the mitotic spindle, it can affect any tissue with a high rate of turnover, which explains the common side effect of gastrointestinal distress, such as nausea and diarrhea, that was often mistaken for a purgative effect in historical texts. Furthermore, its metabolism is heavily dependent on the cytochrome P450 system, specifically the 3A4 isoenzyme and the P-glycoprotein transport system. This creates a high risk for drug interactions. For example, the concurrent use of certain antibiotics or calcium channel blockers can lead to toxic accumulation of the alkaloid, resulting in severe bone marrow suppression or neuromuscular toxicity. While this crocus-derived treatment remains a cornerstone for managing the acute phase, modern science has supplemented it with strategies that address the underlying metabolic imbalance. For those whose bodies overproduce the offending substance, medications that inhibit the xanthine oxidase enzyme remain vital. For others, particularly those with normal renal function who struggle to clear the substance, agents that block the reabsorption of urate in the proximal convoluted tubule provide a way to enhance its excretion in the urine. However, these uricosuric drugs must be avoided in patients with a history of kidney stones to prevent the formation of new crystalline obstructions. The transition from the ancient herbal dressings to these modern targeted therapies marks the triumph of biochemistry over superstition. The autumn crocus no longer serves as a mystical purgative, but as a precise tool for interrupting the cellular machinery of inflammation. By understanding the pharmacokinetics of this ancient remedy and its interactions with the renal and hepatic systems, the modern clinician can provide relief that is both effective and safe, finally quieting the exquisite pain that has plagued humanity since the era of the pharaohs. The journey from the medieval Islamic texts to the contemporary pharmacopoeia demonstrates that while the disease of kings remains a constant, our ability to dismantle its molecular foundation has reached a level of sophistication the ancients could only imagine. The discovery of the uric acid molecule by Carl Scheel and its subsequent quantification in human serum by Alfred Baring-Gerard transformed the clinical approach to this ancient malady, from observational to analytical. Gerard's seminal work established that the core pathology was not a vague humoral imbalance, but a specific chemical excess within the circulatory system. This realization paved the way for the development of pharmacotherapies aimed at the upstream enzymatic processes of purine degradation. The most significant advancement in this regard was the introduction of allopurinol, a structural analog of hypoxanthine. This agent functions as a suicide inhibitor of xanthine oxidase, the critical enzyme responsible for converting hypoxanthine to xanthine, and subsequently xanthine to uric acid. By halting this metabolic progression, the drug lowers the systemic concentration of urate, allowing previously deposited crystals to slowly dissolve back into the plasma for eventual renal clearance. The clinical utility of such agents requires a deep understanding of metabolic timing and the risk of paradoxical flares. When initiating therapy to lower urate levels, the sudden shift in serum concentration can cause the partial dissolution and destabilization of established tophi, releasing crystals into the joint space and triggering an acute inflammatory episode. Consequently, these long-term preventative agents must never be started during an active flare, and they are typically paired with low-dose anti-inflammatory prophylaxis to bridge the transition. Furthermore, the role of the kidneys in this metabolic cycle is paramount. Because allopurinol is metabolized into oxypurinol, which is primarily excreted by the kidneys, the dosage must be meticulously adjusted in patients with chronic kidney disease to avoid accumulation and life-threatening hypersensitivity reactions. Modern management also accounts for the genetic variations that influence drug safety. Certain populations carry a specific genetic marker known as the HLA B 5801 allele, which predisposes them to severe cutaneous adverse reactions, such as toxic epidermal necrolysis, when exposed to xanthine oxidase inhibitors. Beyond enzyme inhibition, recent decades have introduced recombinant versions of the enzyme urate oxidase or uricase. While humans naturally lack this enzyme due to an evolutionary mutation, these therapeutic proteins can rapidly convert insoluble uric acid into the highly soluble compound allantoin. This is particularly vital in emergent scenarios where a massive and rapid release of intracellular purines occurs, such as when chemotherapy initiates the widespread destruction of malignant cells. By converting the urate into a more excretable form, these treatments prevent the acute crystallization within the renal tubules that leads to obstructive failure. This shift from the herbal purgatives of the past to the molecular precision of the present allows for the comprehensive management of the disease, moving beyond the simple alleviation of pain toward the total correction of the underlying biochemical error. This trajectory from Scheele's laboratory to contemporary genomic medicine ensures that the metabolic burden of the disease is controlled at its source, preserving both joint integrity and systemic health for those once destined for a lifetime of recurring agony. The mid-20th century transition from folk remedies to standardized pharmaceuticals marked a pivotal shift in the clinical management of inflammatory arthritis. The historical use of rosemary wraps or raw beefsteaks was predicated on the idea of drawing out internal heat or absorbing morbid humors through the skin. Modern medicine, however, recognizes that the cutaneous warmth associated with a flare is a systemic inflammatory signal, and topical applications do little to address the underlying hyperuricemia. The introduction of Xyluric represented a departure from these localized symptomatic treatments toward a systemic metabolic correction. By addressing the imbalance at the level of the xanthine oxidase enzyme, it became possible to prevent the deposition of the crystals that trigger the intense immune response. This shift was especially critical for patients with underlying metabolic syndrome, as the presence of gout is often a harbinger of broader cardiovascular risks, including hypertension. The modern understanding of this condition and reveals that it is rarely the result of a single dietary choice, but rather a complex interplay of genetic predisposition and physiological stressors. For instance, the presence of glucose 6-phosphatase deficiency, or von Gierke disease, leads to an accumulation of ribose 5-phosphate, which in turn accelerates the production of purines and subsequent urate levels. Additionally, the role of certain life-saving medications must be considered. The use of cyclosporin following organ transplantation or the administration of low-dose aspirin can significantly impair the renal clearance of organic acids, leading to secondary flares. This multifactorial etiology underscores that the disease is a serious medical condition rather than a simple consequence of gluttony. The persistent stigma associated with the disease remains a significant barrier to effective care. When patients perceive that their condition will be met with jokes or lack of sympathy, they may delay seeking the prophylactic treatments that are essential for long-term health. This delay increases the risk of chronic complications, such as the development of urolithiasis or the irreversible erosion of bone density at the joint margins. A comprehensive awareness of the long history of the disease serves to deconstruct these harmful archetypes. It reframes the condition not as a moral failing, but as a manageable metabolic challenge that requires consistent pharmacological support and a nuanced understanding of renal and hepatic physiology. By acknowledging the complex legacy of the king of diseases, clinicians and the public alike can move toward a more compassionate and scientifically grounded approach to one of humanity's oldest and most painful afflictions, ensuring that patients receive the support necessary to lead full and active lives.